All right, thank you very much to everybody for coming. My name is George Francis, and I'm a rehabilitation physician or physiatrist, and I'll explain a little bit of what that is, and I'm going to give a brief talk on rehabilitation in oncology, as mentioned. And so what is rehabilitation oncology? It's a program that's part of the overall oncology system here in Calgary and throughout Alberta. And we mainly deal with the functional changes that happen as a result of cancer or its treatment. And so what we try to do is to adapt to changes that have happened physically or try to restore them as best as we can to increase how independent you can be, to help find relief and control of symptoms, in addition to what some of the other disciplines like palliative care do, and to try to adapt to not only physical changes, but cognitive changes, because cancer and its treatments do affect things like how you think, how you learn, and how you remember information, and how all that fits into your life. So dealing with the emotional, the social, the work, and the leisure issues, and how they can all be impacted by functional changes. In terms of who can be seen by rehabilitation oncology, essentially anybody who is an adult with cancer and has had any effects from it that are affecting function can be seen by our program. And there are both one-on-one sessions, either with myself or some of the other therapists, or with group sessions and classes. So who is in rehabilitation oncology? So there's physiatry, which is myself. There are physiotherapists, occupational therapists, there are therapy assistants, and there are speech language pathologists. I'll talk a little bit about what each of our roles are. So first of all, what is physiatry, or what is a physiatrist? So we're a medical specialty. We're also known as physical medicine and rehabilitation. And we deal with any issues that impair function. Most of the time, this has to do with issues that are affecting the bones, muscles, tendons, and nerves. So basically structures that help us to move and to feel and give us strength. And cancer and any type of cancer and tumor can affect function. And breast cancer has many impairments that can affect your function that I'll talk about. So who are some of these people and what do they do? So occupational therapists help with developing skills to improve productivity and independence in just everyday tasks. So they'll look at, do you need certain devices or equipment for day-to-day activities? They can do screens of your thinking or your cognition and seeing what can help in terms of improving that. If you have any wounds or other difficulties that you're dealing with bowel or bladder issues, then we'll look at different products that can help with that. And education around function and how you can optimize your day-to-day activities, as well as if you're having difficulties with movement or pain, can splints or braces help? Physiotherapy is the discipline that most people are pretty familiar with out of all of us, but physiotherapists help to try to regain and maintain physical function, strength, and movement, particularly with walking, mobility, and moving the arms and the legs. So that includes strength, range of motion, transfer, so moving from a chair and standing up, balance and mobility, looking at, do we need any equipment to try to help with some of these things? If pain or other symptoms are affecting physical function, how do we try and manage those? And lymphedema, so if you're having lymphedema or swelling in a particular part of the chest or the arm, or even the leg, how do we help with that? And what is safe or what is not safe, to try to make sure that we keep both strong as possible, but as safe as possible, in preventing things like falls and injuries from happening. Therapy assistants work with both physiotherapists and occupational therapists to help perform exercises and therapies that are prescribed. So these could be things like balance classes, strengthening classes, and weekly exercise classes. And just looking at how you're doing the exercises and making sure that they're being done both properly and in a way that is optimizing what you get out of them. And then physiatry, myself, as mentioned, it's a doctor specializing in physical medicine and rehab. So I work both with the therapist, but then I also kind of oversee the medical side of rehabilitation. So I look at, in terms of your overall medical issues, how are things going, and is rehabilitation able to be optimized with how you're doing? I can recommend things with respect to return to work. And if there are issues going on that are happening functionally, such as pain or nerve issues, and we don't know exactly what's going on, then I can try to help with different tests and different interventions, such as injections, to try to help with the pain. And then just sort of following things along and seeing how things are going, so that at any point, if things need to be revisited, if we need different types of exercises or different treatments, then I reevaluate those things and trying to help understand, what does all this mean? You know, in terms of what is your function going to be like, what are you able to do and not do, and that sort of thing. So an example of how that team overall works is if a patient has a pain that has occurred from some aspect of their breast cancer or their treatment and they get referred to the program, I may see the person and try to figure out why they're having that pain, diagnose the reason why, and then from there prescribe medication or injections or whatever I think would be most suitable for the person. And then physiotherapy, we'll see the person and create an exercise plan. The therapy assistant would then carry out the exercises. And occupational therapy would discuss how to pace things in context of pain. And then most of the team would meet with the patient once every few weeks to see how things are going and then adjust things as needed. The goal of rehabilitation is empowerment, which kind of goes along with the name of this webinar. But the goal is to get to a point where you're comfortable doing things and that you don't necessarily need to rely on having to go to a place every day or every week, because that can be cumbersome. But to get to a point where you're comfortable doing it and able to go with your day-to-day life without having to be attached to a hospital or another center. And so that's what we try to do in our rehabilitation program. So in terms of some of the issues that we see very commonly, particularly in breast cancer, I'm just going to quickly touch on them just so that people understand, if you have any of these issues going on, then perhaps rehabilitation oncology could be helpful for you. So lymphedema is a very common one. When you have abnormal fluid that develops in the arms or the legs when lymph nodes are damaged or removed, and they commonly happen in breast cancer patients. Up to 30% of people who have had breast cancer may have it after treatments have damaged the lymph nodes or removed them. In terms of knowing what happens when you have lymphedema, most obviously you'll see swelling, but it can also happen without seeing that swelling. You can have a feeling of subjective heaviness and feeling like you're getting more numbness or more tingling happening in your arm and into your hand. You can have decreased mobility and range of motion, meaning that it's more difficult to bend or straighten your elbow or your wrist or your fingers, and pain can accompany all of these things. And in terms of what we do, so our therapists are very well versed in lymphedema treatment, so they can do many different things as part of a comprehensive treatment plan. So that can be bandaging and using garments that you wear during the daytime or nighttime, depending on the symptoms. Manual massage or lymphatic drainage, which is very specific in how it's done, and knowing how to care for your skin to prevent any further complications such as open wounds or infections, how exercise helps and fits into the picture, and just knowing these things going forward so that you can best manage your lymphedema and know at what points would you need to come back and have it reevaluated if needed. Post-mastectomy pain syndrome, it's a long term to basically say that after a procedure involving breast cancer treatment with surgery, and it could be any type of surgical treatment, that you can have pain, which is very common. Up to 70% of breast cancer survivors can have this. And it can be pain in many different areas: the chest, the back, the armpit, and the arm. And it can come from many different factors. So the cancer itself, surgical treatments and radiation treatments and chemotherapy can contribute to it as well. And many different structures can be affected. So it can be partly muscle pain, nerve pain, bone pain, and everybody is different. So it's important to be seen to know exactly what is contributing to your pain. And then from there, we can look at prescribing and recommending different treatments to try to help with it. It's very difficult to make it go away entirely, but we can try to make it as manageable as possible. So this could be medications, injections, pain creams, exercise programs, learning how to pace yourself and using devices to make things easier, and just knowing what movements you should or should not necessarily do and what is safe. Fatigue is also a very big one. So again, a very common symptom due to the cancer itself or any treatments. And while fatigue plagues nearly everybody who has cancer, there are not a lot of treatments that we know that help at once. So it's kind of looking at doing a couple of things over a long period of time. And the biggest one is exercise. And so if you know about ACE, or the Alberta Cancer Exercise Program, which is also known as Excel if you're outside of Calgary, it's a great exercise program, which really helps to try to battle fatigue and try to manage it as best as possible. And Wellspring also helps as well. Our therapists will look at helping with some of the exercise as well and the education around it. And occupational therapy is good at looking at your day-to-day schedule and activities, especially if things like work or specific routines are involved, and how to pace yourself in those. I'll also look at if certain things need to be considered, such as other medical problems or blood tests that might be contributing to your fatigue, and certain medications might be able to help as well. And peripheral neuropathy, this is a very big one in terms of nerve damage that occurs to the feet and hands most commonly due to chemotherapy. And it most commonly happens within a month after finishing chemotherapy, but some patients will get it a couple of months later, and it can get worse even after the chemotherapy is finished, and everybody's a little bit different. And some of the things that people may feel or not feel would be pain in the hands and the feet, numbness or loss of feeling, tingling, feeling like your hands or feet are falling asleep, and it can affect things like your balance and your coordination. And so there's lots of different things we can do for this. So there's certain medications, exercise programs, and so we often use specific agents. I won't go into the specific types of medications that we use, but there are lots of different options that we can try, as well as looking at how we can look at how sensitive the hands and feet are, and using different therapies to try to help manage that. And then other alternative therapies such as mindfulness and acupuncture and TENS machines can be very helpful as well. And bone pain. So bone pain can be due to hormone medications if you're on these medications for several years in survivorship, or if there's tumor that has spread to the bones. And pain could be anywhere just depending on where tumor may be, or because of side effects from the hormone medications, then they can be everywhere sometimes. And so there are radiation and surgery treatments that can help, but in terms of rehabilitation, looking at different exercise programs and trying to maintain and build muscle mass really helps with some of this. And then cognitive dysfunction. So if you have troubles with what we commonly think of as brain fog, so your memory's affected, your attention is affected, and you feel like you have a cloud around your brain where you're having trouble processing information, then medications can be used to try to help with this. And again, occupational therapy and exercise are very, very helpful. So if you look back at all of these different issues, you'll notice that they all have very common themes of exercise being a treatment, and education being a treatment, and safety being a treatment. And that's why rehabilitation is important, because it can help with a lot of different things at once. So how do you get to the Rehabilitation Oncology program? It requires a physician referral. So either a family doctor or an oncologist typically makes the referral. And I've included a link in terms of the website and program brochure so that it can reiterate a little bit of what I was talking about and about the program itself. And we have physiotherapists who look at the referral and then say, okay, you should see physiatry first, or you should see physiotherapy first. And we make sure that you see everybody that you need to see. In terms of where we are in Calgary, we're at the Holy Cross Center in the second floor, and we will be moving to the new cancer center as well. There are also locations in Edmonton, Lethbridge, Red Deer, and Grand Prairie. And finally, I just left some websites in terms of different resources. So there's us, but there's also ACE and Wellspring, which are great resources. And rehabilitation on its own can only go so far. So psychosocial oncology and palliative care are so important, and all of our work together hopefully helps people here with the symptoms that you're having. That's everything I had. So thank you so much for your time.
So much, Dr. Francis. And while you were talking, there were a couple of questions in the chat box, and I've tried to answer them from my perspective from palliative care, but I'm curious in terms of from rehabilitation oncology, yes, if there would be any differences. One specifically pertaining to peripheral neuropathy, and somebody is saying that they're kind of experiencing more at night. And the second question is experiencing more from the site of treatment or the side of the body that received treatment.
Right. Thanks so much. Yes. So Colleen, thank you for both of those questions. So for the first question, yes, it is very common during sleep, and people do find that that's where it becomes more functionally debilitating, and that people feel the burning or the pain or even the hypersensitivity of the blankets rubbing across your feet or your fingers, and that's when it really bothers people. And because it affects your sleep, it then affects you during the day because you're more tired and less able to do things. And so that is very common. And so a lot of our treatments aim at how can we try to decrease that pain at night. And for your second question, you asked about the symptoms being more prominent on the treatment side. So with respect to things like lymphedema and pain following surgery, absolutely, they tend to be more on that side. If it's something like nerve issues or something that systemic treatment like chemotherapy, which affects the whole body, has affected, then it tends to be equal on both sides.
Thank you, Dr. Francis.